I'm going to just go through today and, try to fit as much as I can in 1 hour. I know that last time we got into a little bit of discussion about different aspects of anxiety and the DSM, and we were not able to really get to the core of it, which is some of the treatments and things that we can do for our kids. So today I'm going to try to go a little bit faster, perhaps, and go over some of the basic details and then talk more about treatment.
Great. Go right ahead. It sounds wonderful.
And so if I'm going to start, and for those people who did attend and watch the November 27th show, forgive us if it's going to be a little bit of repeat material.
We love a refresher.
Okay.
A refresher's always good.
So we're going to talk about anxiety and OCD, obsessive-compulsive disorder, and how they have overlaps or comorbidities with our field of ASD, or autism spectrum disorders. So we're going to talk very briefly about how we can identify anxiety in ourselves, because I sort of want to make sure that the listeners are able to identify what anxiety actually is and some of the symptoms. And if you get good at identifying it in yourself, then it helps you very much to identify in your children, especially our children, because our children, of course, have a very hard time expressing it when they have anxiety. So, and we'll review what is anxiety, what is OCD, and what are some of the signs of anxiety and OCD that we see in ASD and autism. And then I'll throw out some ways that we've used in the past to assess anxiety in our kids, and we'll talk more about treatments.
Great.
Okay, so we talked about the definition of anxiety, and again, for our viewers, this presentation in its entirety will be up on the Act Today website, the CARD website, the autism-live website, so that people can access it freely.
Absolutely. And
possibly even the video might go up as well, so that people can see this. Okay, so anxiety is really a normal reaction to stress, and it does, a certain level of anxiety is important. If we had no anxiety, nobody would leave their house and you'd just stay in bed and not care about anything, right? So a certain amount of anxiety makes us functional, and so that's kind of important to know. It helps us deal with difficult situations, and often when you look at people who are good high performers on examinations, for instance, those are people who have a mild level of anxiety and not the people who have no anxiety or high anxiety. So just so you know, a mild level of anxiety is a healthy thing. Okay?
Good to know.
Now, when we look at ourselves, the things that we tend to call anxiety, and this was something I just polled a bunch of friends. And I said, when you feel anxious, how do you feel? What are some things? And these are the things they listed out for me, and it might not apply to everyone here, listening, but, here they are. I worry, I'm afraid, I don't sleep, I don't eat, I eat too much, I obsess about things, I have racing thoughts, I have heart palpitations, I have irritable bowel syndrome when I'm anxious, I feel dizzy. So people feel anxiety differently, okay? I think for me, I have racing thoughts and I don't sleep. Other people have different levels of anxiety. How do you experience anxiety, Shannon?
I think I have everything on the list except don't eat.
Okay, sadly. Sadly, that's the one you want to have. Yeah. And then if you think about how do I deal with anxiety when you have those symptoms, right? What do you do? And here's again, same group of friends. I distract myself, or I keep myself busy. I talk to my friends. I gain reassurance. I pray. I take medications to help me. I exercise. I breathe, I meditate, I do yoga, I practice positive self-talk, I try to change my beliefs, I avoid what's making me anxious, I take drugs or alcohol or other addictions, I try to change what is causing me anxiety. Okay, so 2 points about this list. Some of these things are adaptive, like, kudos to those people who actually exercise when they have anxiety. What a wonderful thing to do. Or meditate or do yoga. And then some of them are not so adaptive. They're not it's not a good idea to drink alcohol when you have anxiety. And the idea here is that people deal with anxiety in different ways. Sometimes if it's overwhelming, you might end up doing something not so good. And if you've dealt with it more in your life, and you get better at dealing with it, right? And the second point about this slide is that when you look at these things, you have to realize that our children don't know how to do most of these things. When kids experience anxiety, any child, they don't really know how to cope with it. They don't have these, what we call, coping mechanisms. Whether they're good or bad, kids don't know how to do any of these things, usually. So they just, go into the previous slide, which is they just continue to worry. They just avoid. They just, they do things they just experience it over and over. They don't know how to reduce the experience of anxiety. And that's important, because that takes us to treatment. Right?
And absolutely. And I feel like even already knowing that, it makes me so much more motivated to provide my child with skills to be able to cope.
Exactly.
Because if I didn't have skills to cope, it would escalate.
Exactly.
And I would feel terrible allowing that to happen to my child.
Right. And, it's important to just the two slides that we went through. What I want our viewers to hear is, you will sometimes see symptoms in your child and you won't relate it to anxiety. So, for instance, let's see, your child's not sleeping or not eating or obsessing about things. Now, this is very important. When we see those obsessions, for me, the number one thing is, why does he want things to be a certain way? Why is he all of a sudden now concerned about things being perfect? Those types of things are clear indications of anxiety. And before I start, as I start to try to teach my child not to, line things up or not to insist on things being perfect, I also want to teach him some coping mechanisms.
Absolutely.
So there's two sides to it. So this is just kind of like, let's let our viewers think these things through.
Sure.
Okay. Now, as behaviorists, the way that we have to remember, and I'll go back to what the behavioral concept of any behavior is that everything we do is to get something good or avoid something bad. Remember, that's what I always say, right? Feeling anxious is obviously something bad. It's not a good feeling. So sometimes what we do is we avoid all situations that cause anxiety, right? Like examples of this are not wanting to go to school. Maybe some of our kids don't want to go to school because they're anxious in that environment. They don't want to go to a party where there's a ton of noise, because the noise level makes them feel anxious because it's too intrusive. They don't really want to go to social situations because they're not good at being social. These are just examples. And if you can't avoid the situation that's making you anxious, then you tend to do things that will help you cope. Some of the things you do to cope are good, and some of the things you do to cope are not so good. They're all coping strategies. Even if let's say something that is good, a good way of coping is let's say they force you to go to, here's a good example. People don't realize the number one thing, public speaking is a huge anxiety-provoking situation for most people. So let's say I force someone who doesn't like public speaking to go into the public speaking situation, and boy, they start showing all symptoms of anxiety. They're nervous, their hands are shaking, they're sweating, all that sort of stuff, but I force them to do it. Now they're going to start to cope. Now, some people will cope in a way that's adaptive. So, prior to going, they'll practice a lot, they'll breathe, they'll know, they'll start to push their thoughts, their anxiety thoughts away, and so on. Other people will do things that are not adaptive. They'll have a tantrum. They will, refuse or throw things away, around or whatever. They'll put up a fight, So coping mechanisms are good and bad.
Okay.
With all these coping strategies, what are we trying to gain? When we do coping strategies, we're trying to avoid or reduce anxiety. We're trying to find other things that are rewarding so that they replace the anxiety. That's why we eat, right? Overeat or drink alcohol or whatever. We're trying to reduce the anxiety by replacing it with something else. We try to gain better understanding of what is causing us anxiety, and we want to change our perceptions and beliefs, because anxiety altogether is just something we believe, right? People who go, I mean, there's some people that are very, very comfortable with public speaking. I have no anxiety about public speaking, but other people who find public speaking to be extremely anxiety provoking. So if one child finds a social situation to be anxiety provoking and another doesn't, it doesn't mean that our child who's anxious is doing anything wrong. People are different. Their skill set is different. The very, very first time that I spoke in front of 1,000 people, I was pretty anxious, and I rehearsed my talk maybe 20 times. Now I will go and do a talk with absolutely no rehearsal, and I'll just talk to the audience. So practice or knowing content or knowing what we're doing helps us reduce anxiety. And that is really important when it comes to our kids, because our kids have learned the language recently. They have learned social skills recently. And all of these skills are new to them. So when we force them into situations where we feel they shouldn't really be anxious, we're wrong. They have every right to be anxious. We're asking them, our kids should be anxious every single time they get into a conversation because it's brand new to them.
But that's not a reason to not have them do it.
Oh, absolutely. You will continue to place them in those situations. But as we go on, and you'll see, there's a lot of things you can do to gradually fade the child in, to give the child other forms of support, to make the situation more palatable so that the child doesn't go to high-level, horrible other coping mechanisms that are not good.
Okay.
We tend to do drastic things when we're placed under a lot of pressure all at once.
Yes.
And if we are gradually exposed to things, then we tend to cope better and have more healthy coping strategies.
Because I sort of see it as the avalanche, that the child has some anxiety, and maybe we don't even realize it's anxiety, but we take them to a birthday party and they have the meltdown because of the anxiety. And then the next time the birthday party comes up, the child is showing reticence, and then we have anxiety about it because we don't want to go through the thing. And so it just becomes this mushroom cloud.
Right, absolutely. Very good example. And if in that scenario, if the child had been prepared a little bit more for the event, the whole thing would have been more successful. So it's just a matter of preparing ourselves a little bit better and perhaps reducing the exposure to a gradual exposure. When you have a situation like taking a child to a party and they don't have the skill set, or B, the noise level is too high and it's bothering them, or C, they're not allowed to even reduce their own anxiety by eating a lot of the foods because the foods are restricted. So there's a lot of stuff that goes on. When you're doing that, you're flooding. That's a procedure called flooding, and you're basically exposing the child to multiple aversive stimuli all at once. Versus shaping, or a graduated type of, procedure where you're not really placing the child in a horrible situation, you're just gradually increasing. Well, I'll give some examples.
Okay, great.
So, and did I go through this slide? Yes. So if our children now this is going on to talk just briefly about how difficult it is for us to even see anxiety in our kids and to identify it. And again, remember I think it might come up in this presentation, but in autism, because it's such a pervasive disorder, people tend to, it overshadows everything else. We've talked in the past about, so many of our kids have gastrointestinal issues, and the doctor will tell them something like, oh, that's just, a lot of kids with autism have GI issues, which means nothing. And we just tend to then ignore those issues. And same thing with anxiety. A lot of our kids have anxiety. That doesn't mean we have to ignore it.
Right.
It's not one of the symptoms of autism. It's one of the side effects of just not having enough communication ability and having too much intrusion and not being able to fit in and so on. So then you feel anxious.
But I think that's why this conversation is so important, because I think a lot of us have felt helpless about our child's anxiety.
Right.
Is there something we can do? Is there a strategy? And that's why I'm so thrilled that you're talking about this.
Absolutely. And that's the thing, when we put it into the bucket of autism, then we feel like, oh, that's pretty scary, right? I'm not just can't deal with this. But it's because the bucket of autism is so just hidden, and like nobody knows how to deal with this huge thing in there. You know,
mysterious. It still has this air of mystery.
Exactly.
The doctors act that way, like, well,
oh, nobody knows how to do it.
Yeah, right.
But anxiety is anxiety, and there's been for hundreds of years ways to treat anxiety, and you'll see that some of these treatments will be very effective for our kids.
Okay, awesome.
So, if our kids had anxiety, would we even know it? How would they show us? It's very important for us to see this. What ways do they have to cope? And what techniques do they know to calm themselves? And can we help reduce what causes them anxiety to begin with? So it's one thing to say they're anxious, let's teach them coping mechanisms, which we will. But the other thing is, remember, everything you want to change consequences and antecedents. Can we actually reduce some of the stuff around them so that their anxiety level is low to begin with?
Okay.
So there's many ways to think about it.
Okay.
Our goal is to recognize anxiety in our kids, help them recognize what makes them anxious, because you're not always going to be there.
Right.
So you want your child to be able to realize, okay, I'm going to be anxious. The reason my heart feels this way is that I'm experiencing anxiety. This is what I need to do. Help find good coping strategies. Help them feel confident enough to approach situations that they feel anxious about. Help them overcome their anxiety overall, and then help them find ways to reward themselves, right? Because you want your child to be independently able to push themselves. My son, he gets very anxious about memorizing new academic information, which is really interesting. Like if it's, last time we were practicing French and he was saying, I just can't get this stuff, I have horrible memory, which is fascinating because he's an actor, he loves acting, and he memorizes books of script, books, like literally, way beyond my memory. And what he doesn't realize is memory is memory. Right. It's just that he knows he will be successful memorizing script, but he feels he will fail at memorizing French. You know what I mean? So it's sort of an interesting thing. And the main thing is to teach our kids, okay, this is how I go about coping with this. I'm going to introduce myself to this scenario gradually. Because as long as someone else is pushing you, you're going to have resistance.
Yeah.
So it's important to teach our kids to approach it themselves. We went through this a little bit last time now, this slide, where we talked about in DSM-4, the anxiety disorders were defined this way, and there were, it was panic disorder, separation anxiety, specific phobias or fears, social phobia, obsessive-compulsive disorder, post-traumatic stress disorder or PTSD, generalized anxiety. These were all classified in the chapter called anxiety in the previous diagnostic manual. In the new manual, in DSM-5, it's a little bit different. They actually have added a whole section now, and what they've done is for anxiety disorders, they've detailed it a little bit more. So we have separation anxiety, selective mutism, which we talked about, which is sort of kids where you will essentially in certain situations you freeze and you don't speak, you don't talk. Specific phobias, again, social anxiety or social phobia, panic disorder, agoraphobia, which is a very extreme level of anxiety which prevents you start to stay at home and don't want to leave your environment because you only find your own environment to be safe. Generalized anxiety, which is anxiety in more than one situation. Substance or medication-induced anxiety, which essentially means, and this is actually a very good one that they've added, because a lot of medications, like medications for ADHD, will tend to increase the heart palpitations, and sometimes you misunderstand that feeling and consider it to be anxiety. A lot of medications do that, actually. Anxiety disorder due to other medical conditions, like let's say if you are going through chemotherapy or something, you're going to feel pretty anxious because you feel sick, and just feeling nausea. Nausea is one of those feelings that people relate to anxiety a lot. So if other things cause you nausea, you're also going to start feeling anxious. It's funny. And then other specified anxiety and unspecified. So they've just kind of detailed it a little bit more, the anxiety disorders chapter. And they've added another they basically are defining the anxiety disorders as things that are disorders that share excessive fear, okay? And they're clarifying in the new diagnostic manual. We did, I think, talk about this a little bit, where they said that fear is the emotional response to real or perceived imminent threat. It could be real, it could be perceived. And anxiety is the anticipation of that threat, right? So I, in my mind, think that something really bad's going to happen, whether it's real or not, and then I feel anxious, apprehensive about it before it even happens, right? And that's anxiety. Anxiety is usually about real life events. Not necessarily, but usually. Your perception of the real life events could be completely wrong. Like a real life event would be going to school, and your perception of it would be, all kids are going to make fun of me today, right? So your perception might be completely wrong, but it's still a real life event that could potentially happen.
I like when people say fear stands for false evidence appearing real.
Exactly, very, very good. That's an excellent way to put it. And there's a huge overlap with OCD, because OCD, now they've put a new chapter called Obsessive-compulsive disorders. They've separated it from anxiety because they say that the fear that is in obsessive-compulsive disorders is usually irrational. The only separation then is, okay, so we have, I'm going to school as a very real thing. I might have a sort of a perception of going to school that's a little bit exaggerated, like people will make fun of me, or I might say, oh, today something's going to fall from the sky and hit me in the head and I'm going to die today. And that's a little bit more irrational. And if you go to kind of things that are a little bit more irrational, and it results in you doing irrational behaviors, your behavior might become obsessive-compulsive in nature. And so they're trying to make a distinction between the type of fear that leads to just a generalized anxiety or an anxiety disorder and the type of fear that leads to OCD or obsessive-compulsive disorder. But I don't care. Let's ignore that for a minute, because if you can see on this bullet, there's about 76% of overlap. In other words, if you feel you have anxiety, 76% of the people who have anxiety also develop obsessive-compulsive disorders. 76% of people who have OCD is due to some form of anxiety. Wow. So it's a high overlap. I don't think they should have divided these two. And I think the reason, and as you recall, DSM-4 did not divide them. They said OCD is a portion of anxiety, and I truly feel it is. The reason they divided it is simply because they would have otherwise had about 20 different disorders under the same heading.
Okay.
So, when we look now at the obsessive-compulsive and related disorders, this is the new chapter, they say that these are characterized by the presence of obsessions and or compulsions. So you might have anxiety about something, but not obsess, okay? And so that's sort of a difference. If you are obsessing, then perhaps it has already turned into an OCD, an obsessive-compulsive disorder. What are obsessions? Obsessions are recurrent and persistent thoughts, urges, or images in your head that are experienced as intrusive and unwanted. Remember in the very first slides I said that one of my friends had said racing thoughts? That's what obsessions are. Obsessions are racing thoughts. They're like, and then they will make fun of me, and then what will happen? Oh my God, and then that'll be so embarrassing, and I don't know how to handle that, and then the teacher won't stand up for me, and then I'll have to run away, and it'll be horrible. And it's just like, turning things into, it's like a dream state. Right? Often when we push away our obsessive thoughts, they come out as dreams.
I call it going down the rabbit hole.
Yeah.
You just keep falling,
exactly right.
And you keep seeing, it's like Alice in Wonderland. She goes down the rabbit hole and it just gets worse and things get big and small. And
exactly. And before you know it, something that was going to school, something that was kind of benign, has now turned into entering a concentration camp.
Right.
It's now turned into something horrible in your mind. And as a result, you tend to become compulsive. Now, this is the compulsive portion of the OCDs, which is Compulsions are repetitive behaviors or mental acts that an individual does or feels driven to do in response to the obsession. So, oh my God, they are going to torture me at school, and now I will start to do certain meaningless, in some ways, repetitive behaviors that will keep me safe. So it's one thing if I put up a tantrum and avoid going there, but it's another thing if I have to make sure that my backpack is green, because having a green backpack will save me. Or I have to check and make sure everything is perfect, because if it's not, I'm going to fail. It's going to be disaster. One of my kids, my daughter, when she was really little, was very much a perfectionist, perhaps my fault, in school. And she really wanted, she still is, Nikki, she still is, and she wanted everything to be, she wanted straight A's, she got a 4.0, by the way, at the first semester, first quarter at college, yeah. And she is, just was that way when she was young, and it had gradually become compulsive, her behaviors, in terms of the night before an exam, she had to go through these specific rote rituals, which had really nothing to do with tomorrow at all. And we often do these things. How many people listening here or viewing this don't have a lucky something? Right? You have a lucky rabbit's foot. Where on earth did we get that from? Right. That's a compulsion.
Yeah.
To have something that brings you, that you feel luck, that brings you luck, or those are compulsive types of things. They are irrational. They make no sense whatsoever, yet they are mental acts. They give you some sense of security, right? Okay. And we often do a lot of repetitive behaviors, or behaviors as a whole, like the people who have pure OCD washing their hands because they feel that there's germs.
And then and when you bring up repetitive behaviors, of course, this is part of our autism diagnosis.
Which is exactly the slide we're going to look at right now.
Great. Fabulous.
And so, again, I'm trying to help people understand that OCD, or obsessive-compulsive disorders, are really anxieties. And now we're going to look at the obsessive-compulsive disorders, and I've specifically highlighted in red the ones that I feel we very clearly see in our children in ASD. So these are the ones that are listed under the new chapter, right, under the OCDs. And remember, the OCDs as a whole used to be classified under anxiety, and we've already said they are 76% overlap with anxiety. This is all about anxiety.
Yeah.
The only difference is they tend to turn into coping strategies that are strange, that consist of repetitive behaviors and compulsions.
Okay.
OCD itself, obsessive-compulsive disorder. This is you obsess. I think I go into them. So you obsess about a certain situation, and then you do compulsions to try to reduce the obsession. Body dysmorphic disorder. We're not going to talk too much about body dysmorphic disorder. This is for people who develop eating disorders, for instance. You're very, very thin, but you still look at yourself and you think you have an obsession about being thin because you think you're fat, and therefore you do repetitive either bulimia or anorexia or other things to make yourself feel better. Hoarding disorder. Hoarders, so people who will gather things and keep them. That's a pure anxiety related thing. Why do we collect things? We collect them because they make us feel safe. You feel protected. You feel like you're never going to lose out in life, because now, one day when you need that flashlight, you have 500 of them.
Yeah.
And you hoard so much that you could never even really find the thing anymore, and it becomes kind of just a protective layer of items, materials. And with our kids, you often see hoarding in the beginning phases. Sometimes you'll have a child who even has a hoarding drawer. Like they have a place where they put all their stuff, or they just carry things in both hands, or they have a blanket, or they have an animal that they have to take with them. Or, certain things have to be a certain way, like they will insist on wearing certain clothes or not other clothes. And these are all, if you really start paying attention to it, these are forms of OCD. These are compulsive behaviors.
Okay.
Trichotillomania is the obsessive-compulsive behavior that some people have, where you pull out hair. You're anxious and you get into the habit of pulling out your hair. Excoriation disorder is actually kind of interesting, and I've highlighted it here because excoriation is people who have anxiety and they pick their skin, right? So a lot of people pick their skin. You see this in our kids quite a bit, actually. Okay. Some of our kids do this to a very, very extreme level where it becomes very dangerous. Substance or medication-induced OCRD, which is the obsessive-compulsive and related disorders, as I mentioned with our children, there are many medications you take. There's a form of niacin. You take niacin, it's vitamin B. It's not a big deal, but it gives you a rush. Yeah. I don't know if it makes your whole head hot for a few seconds. Yeah. And a lot of our kids will experience that as something that is anxiety-provoking.
Okay.
And of course, there's other specified types of this, and then there's body-focused repetitive behavior disorder, which is kind of an interesting one that they've listed here, and it really makes me think of our kids, because it is all of the hand flapping, body rocking, all of these types of things. It's funny, some people in general, when they're anxious, they tend to do things like this. Or, you know, if you really think about it, people, you're anxious and you move your leg a lot, or tap, you know, or like if you just are tapping your hand on the table, those types of things are called body-focused repetitive disorder. And if it gets to a point where it's disruptive, then it can be considered a disorder.
Okay.
I'm going to give a break in a second.
Do you want one now?
No, if it's okay, I want to keep going for a few more minutes because I really want to fit as much as I can in. Some of the commonalities are like cleaning or, you know, contamination disorders. A lot of people experience that something around me is dirty and therefore I have to clean obsessively. Here's one of the cool ones that they've listed now and I wanted to talk about is symmetry, an obsession with symmetry and repeating ordering. Obsession with symmetry means things have to be a certain way that is symmetrical, perfect. Nobody knows what that really is, but they have to be a certain way. And that is so many of our kids where things have to, and that, notice this has nothing, I'm not reviewing autism, I'm reviewing OCD, I'm reviewing anxiety. And these are symptoms of those disorders. So they're, you know, when you have a child who insists on things being symmetrical in a certain way, that's anxiety. It is an indication that they're feeling anxiety. We're going to skip the other two because they're not important to our current discussion here. But what's important here is genetics. When you look at genetic components of obsessive-compulsive disorder, the rate of obsessive disorders, or what's called obsessive-compulsive and related disorders amongst first-degree relatives is double the normal population. The rate of obsessive-compulsive and related disorders amongst first-degree relatives when the person with obsessive-compulsive disorder was diagnosed as a child is 10 times the normal population. So in other words, if you are diagnosed as an adult to have obsessive-compulsive behavior, the likelihood that one of your immediate relatives, like your child, would have one is double. The normal population would have obsessive-compulsive behavior as well. If you are diagnosed to have obsessive-compulsive problems as a child, the likelihood that your child, when you're an adult, will have it is 10 times normal. So there's a huge genetic component.
And what this says to me is that as parents, we have a responsibility to get help for ourselves if we're having anxiety, and that if our children are having anxiety, that we need to get on top of that, or we're going to have grandchildren who have
and you know, it's funny that it's right now, of course, this often happens, and you know, these studies on genetics, they're done with groups of people, and they notice that, oh, if somebody was diagnosed with OCD as a child, they've grown up, and now we're studying adults who were diagnosed when they were kids. But you can also think of it as, is this really genetics or is it really environmental? If someone has OCD as a child and they're not treated, it's very likely that they go through life with OCD and their kids will have OCD. Yeah. I had a parent who used to come to the clinic and she would have a mask over her face and would only come in with a Lysol can, and her child was very, very anxious, and the parent wouldn't let her child go to school because she was afraid that the child would bring germs home and infest the house with germs. I mean, our behaviors really impact our kids' behaviors.
Absolutely.
So this is very, very important to pay attention to.
Should we give you a break?
Let's take a quick break.
All right, we're going to take a break, and we have some questions that have come in, and hopefully we're going to have time to get to some of them. One in particular about helping older kids on the spectrum that are in that transition phase that are experiencing anxiety. So stick with us. We'll be right back after these messages. Welcome back to Ask Dr. Doreen. We're so thrilled that we have Dr. Doreen Granpeesheh with us, and she is doing for us the part 2 of the anxiety show, which I think is going to have to go into part 3 eventually. But we should say that you are someone who has been dealing with autism. You're an expert with the field of autism, and I always like to remind everybody that you're a visionary in the field of autism. And so it's so wonderful to have somebody with your expertise taking this for us and putting it in terms that we can begin to understand, so we can start to help ourselves and help our kids.
Right. Well, thank you. I appreciate that. That's very kind of you. But I really believe that a lot of our kids and adults experience anxiety, and it's one of the things that really is ignored quite a bit.
Absolutely.
And so what I'm going to do now, because I do have a lot of slides, but a lot of questions that have come in have to do with just the treatment aspect of it. So what I'm going to do is I'm going to just tell you about the next slides, and hopefully you will go in and look at this PowerPoint. And I think, Shannon, what we should do for this talk is at some point I'll schedule with Emily and do more of a 2 or 3 hour long video on just anxiety as a whole. So, the next slide was going to talk about why would individuals with ASD have anxiety. And this is really important because, if you just quickly take a glance at these things, our kids and adults on ASD who have ASD experience a lot of things we don't experience. Like, they don't sleep enough. Most of our kids don't get enough sleep. There's a lot of illness stuff. It's funny because if you go to a restaurant, if you get food poisoning and you have severe GI symptoms, the number one thing people with severe GI symptoms say they have is anxiety. It's an identical feeling when you're throwing up and you have diarrhea and so on. It's an identical feeling to when you have severe anxiety. So there's a huge overlap. And if a child has GI symptoms, they're going to feel anxious all the time. Sensory overload makes us anxious, and our kids, we know, have a lot of sensory overload. Being on medications, receiving treatments, like, if you're going to get a methyl B12 shot every 3 days, you have increased anxiety. I don't know how my kids would handle it if I told them you're going to get a shot every second day or every third day. Just imbalances in our neurotransmitters, which a lot of our kids have imbalances, will cause anxiety. And there's a lot going on with our kids that increases their propensity to have high levels of anxiety. And the ways that they show it are they do have obsessive-compulsive behaviors, like lining up objects, which they're trying to control their environment. Hoarding, which gives them a sense of safety. Body rocking, which, by the way, body rocking is one that I like to talk about. This motion actually is one of the few motions that activates parasympathetic activity in the brain. So we have sympathetic activity and parasympathetic. Sympathetic is when you are ready for the fight or flight response, and parasympathetic is the calming response. It's your body is reacting to a stressful situation, and your parasympathetic activates in order to calm you down. This body rocking is one thing that you can do that will actually activate your parasympathetic, which is very interesting because our kids do that. It's almost like they're naturally trying to calm themselves. This is why we have rocking chairs. Rocking chairs produce calming effect because of activation of the parasympathetic. So, and signs of anxiety will result in no sleep, in IBD or other GI issues, hives. I will always check our kids. Or in avoidance behaviors, like things like self-isolation or no eye contact, right? Social avoidance or self-stimulatory behaviors, which are all repetitive and rote. I'm not going to talk about the research findings just because actually, the only thing I want to say about this slide, which is amazing, and I'll be very quick on this, it's just a very spectacular slide. Studies show that individuals with ASD experience greater levels of anxiety than community populations, regardless of their age. All other community populations. Individuals with ASD show greater signs of anxiety than individuals within any other clinical group. This is the good one. Individuals with ASD show similar levels of anxiety when compared to individuals with a diagnosis of clinical anxiety. The only other group they're similar to in their level of anxiety is people who have been diagnosed with anxiety.
Okay.
So ASD is definitely one of those that has high levels of anxiety in it.
Okay.
And of course, we talked a little bit about diagnostic overshadowing and reasons why it's very hard to assess. I've listed a few different assessment tools that might help our people identify but I've already also mentioned a bunch of symptoms. If you see those symptoms, assume that it might be anxiety. Now, we're going to start talking, we have about 10-15 minutes to talk a little bit about treatment here. When you talk about it from a behavioral perspective, remember we always want to look at the antecedents and the consequence of things, right? So you can do an FBA, you can do a functional behavior assessment, and you can observe it and find out what's causing the child anxiety. So time for school, Joe tantrums, and then he gets sent home, right? A challenging behavior, like a tantrum, may begin because there's anxiety. So the antecedent, like time for school, is causing anxiety, and then it becomes learned due to the reinforcement. This is a really important thing. Most avoidance is learned. It's something that we imagine. So I want to avoid school because in my head there's something about school that's causing fear, causing anxiety. Now I'm going to do a huge behavior like tantrum, and then they send me home, and great, now I realize that my tantruming behavior worked. Right? So any behavior that has an avoidance function has some level of anxiety in it, is what I'm trying to say. Noisy environment, Tom lines up toys, right? And then Tom gets to avoid the environment because he's obsessed with his whole thing. Is it okay sometimes to let Tom avoid the social setting, or is it better to help him cope? And those are the questions. You don't want to reward the avoidance behavior, because ultimately all of our kids have to be exposed to situations that are normal, like going to school. Mm-hmm. But there are many things you can do to help. Okay. So there are, first of all, the psychopharmacology treatments, which we don't want to ignore because they're hugely effective. Things like selective serotonin reuptake inhibitors, SSRIs. They're very helpful with this. The SNRIs, or serotonin and norepinephrine reuptake inhibitors. There are many other drugs. Those two are the mildest. Of course, there are others like the benzos are a little bit heavier, but these are medications that have been used for the treatment of anxiety for many, many years. Many years, okay? Mm-hmm. And they will reduce the anxiety feelings. Now, I'm not someone who's one way or another feel very strongly about the use of medications or not, but I will say that research shows that a combination of medication and cognitive behavioral therapy is the most successful. Okay. That is the way to go. So if your child has, or if an adult has very severe anxieties or obsessive behaviors, start with looking at researching the medications for anxiety, and the two top ones are the most common, SSRIs and SNRIs, and you will see that they're pretty benign. They will just kind of take the edge off. They sort of help you. They modulate your neurotransmitters. I can't go into the biochemistry of it too much today, but they really do help people calm down a little bit. Okay. And that kind of helps us then work on other things or teach better, and change behavior better. Keep in mind that there are other medications that help as well. So if your anxiety is coming from having GI symptoms, then take medication for the GI symptoms, So GI meds will calm the GI issues and will help your anxiety as well. If you're having sleep deprivation, get medications that will help your sleep, because lack of sleep leads to significant anxiety. Mm-hmm. I guarantee anyone, set your alarm clock so you don't sleep for 2 nights. You'll be the most anxious wreck that exists. And that's a lot of times what happens with our kids. Yes. We don't realize that they're experiencing anxiety simply because they don't sleep. They wake up too often. Okay, so we have to take care of business, essentially. Exactly. If something's going on, we got to take care of that. Otherwise, we're really not going to be as successful taking care of the anxieties we could be otherwise. Because if you're still not sleeping, I can give you 50 coping mechanisms for your anxiety when it happens, but you're still not sleeping. Right. Like, let's fix the underlying. Okay, great. Then we get to therapy, cognitive behavior therapy. Cognitive behavior therapy's goal is to create new coping mechanisms or new coping templates. And you use behavioral techniques like modeling, exposure, and relaxation. Okay, and we're going to talk about each of those. So exposure, which is the main thing, of course, modeling, that's I don't know if I go into modeling or not, but modeling, most of the time what we're doing is we're modeling bad behavior for our kids.
Yeah.
But because we ourselves become anxious.
Yeah.
But if you, okay, so an example of this is if a parent has serious anxiety about, let's say, spiders, guaranteed all kids in that family will fear spiders.
Yeah.
So if you are able to overcome some of your own anxieties, then you can model for your children. If a parent goes and touches a spider that's not harmful, children won't be afraid either. We learn from our parents what to fear, or from someone else.
Right.
If we see someone scream and freak out, we will realize, oh my God, there must be something to be anxious about. So don't model anxious behavior.
Okay.
Exposure, this is the most critical treatment, and it will help anyone with anxiety, OCD, any kind of phobia, and it is a heavily used intervention. We use it for so many different things. It's called systematic desensitization. Remember when I said flooding is forcing the person to be exposed to the thing they don't like, just throwing them into the anxiety situation? Systematic desensitization is sort of a way of doing that more gently. There's 3 phases to systematic desensitization. There's exposure to a hierarchy. Essentially what you do is you produce a hierarchy of things that are anxiety provoking. So let's say, I don't know, going to a party is anxiety provoking for an individual, and what you will do, or touching let's look at serious OCD, like touching a particular object is dirty. And that is really, I'm going to avoid that completely. So what I'll do is I will have a list of things that are the highest to the lowest anxiety provoking. So the lowest, I'll use an example that applies to many parents, is like taking their child to a medical type of intervention, whatever it may be. Child's freaking out, tantruming, throwing fits, and so on. So you sit with you produce a hierarchy for your child that starts with looking at a picture of a doctor's office. Maybe that's even too anxiety provoking. You go to the very lowest and you'll put 20 items in there, 20 pictures, or 20 steps. The highest would be actually going to see the doctor or the dentist and actually receiving the injection or
whatever
the procedure.
The thing that has the most fear. That's exactly. At the top of the list.
That's at the top, and the lowest is the least. The second stage of systematic desensitization is teaching your child some form of relaxation exercise. Now, this could be anything. It could be breathing. We do a lot of breathing with our kids where you just breathe and count. It could be imagery. So you will teach the child to think of their favorite place, like on the beach, and really do what this is essentially just going in your head and meditating for a while. Or it could be just relaxation.
Or self-talk, or all those things.
Lay down, drawing, listening to music. There's many things we can do that are relaxing. Okay. And then the third component is pairing. So what you do is you now do whatever you're good at that relaxes you. You have to really get good at that, though. Okay. So you do that, and you pair it with the first thing on your list. Just look at the picture, and you do your relaxation until the picture is meaningless. Then the next day or 2 days later, you go to the next stage. And let's say the next thing is, okay, a picture of the doctor, or a video maybe. You watch the video of the doctor doing the procedure, and now you are doing your relaxation and you're no longer worried. The third or fourth day, now you're going to maybe even get in the car and drive to the doctor's office, but you're not going up. That's all. You just drive to the doctor's office and you're relaxing, or your child is listening to their music, and now they're much better. The fourth day, fifth day, it might take a month, doesn't matter. And you just gradually work your way up, and you pair each step with the relaxation procedure. So you might have to drive to the doctor's office 5 times and just sit in the car and listen to music, but you do that until the child is no longer anxious.
So essentially, we've taught them a coping skill, and then we're gradually letting them try the coping skill out in a way that they can be successful, so that we can get it further and further along.
Yes, and you pair the coping skill with the stimulus that's causing anxiety. Yes, exactly. You get what you're doing is you're classically conditioning each level of the anxiety to neutrality, to the relaxation, so it's not going to be anxious anymore.
Okay.
Now, when we do these techniques with our kids with ASD, you use a lot of visual stimuli. Like, I'll give some examples here. A toolbox. So you will teach your adult or child many techniques. One could be breathing. One could be, whenever I feel anxious, I need to listen to music. It helps me. One could be, I like to draw. Drawing calms me down. Whatever they are. And you put them in the child's toolbox. And you help your child pick. The next time they start to get anxious about something, you say, hey, what's in your toolbox? What are your techniques? Pull one out and do it right now. You pick. And you can use visual things to help the child to identify what they have. What are their strategies? You give written schedules. For instance, a lot of times our kids are anxious. This is when parents tell me they hate transitions, right? So write down their entire schedule. Do you know how much anxiety that reduces for our kids just knowing what's coming next? We just take our kids and we do, come on, we gotta go this, this. And the child's like, good Lord, what's happening to my schedule? What am I doing
And
today?
we would react badly if somebody did that to us.
Oh, everybody,
That's what's fascinating. I do it all the time, but if somebody did that to me, I would freak out.
Absolutely. And so it's very important for our kids to actually know what's going on. So transitions are important. Narratives. Narratives are things like you will write, like social stories is a narrative. Social stories, for instance, you can just write narratives like, I am the boss. Anxiety is not the boss.
Right.
That's it. Something like that for the child. They can write it down on a small piece of paper, like one of those things in cookies, put it in their pocket. Whenever they're going somewhere, they pull it out and take a quick look at it and put it back. I'm the boss. Anxiety is not the boss. Just something as simple as that. Stories are very helpful, where you can tell stories of someone who was worried about something and then they overcame it. You role play, just role play the whole thing at home of going to a party or going to school. I mean, it sounds silly, but it really helps our kids. Choice lists, like when you are in an anxious situation, what are your choices? What are the things you can do? It's fine to walk away. That's totally fine. So therefore, what are you worried about? You can walk away from it.
Right.
What are you worried about? If you're at a party alone and you can't get away from the noise, can you go to the bathroom? Maybe it's more. And these are appropriate things. And hey, we do these things. Haven't you ever been, I get anxious because my kids talk to me all at the same time and I've already had 12 hours of work and I'm dying and I haven't slept and there's a million things, and I'll just literally go in my closet and stand there for 5 minutes just to breathe and calm down.
Yes.
Drawings are very useful to our kids, like thought bubbles, cartoons, like helping we do a lot of cartoon comic strips, where our child will, let's say, throw a fit or a tantrum, and then we'll say, okay, let's talk about why this happened. So this is you, and we'll draw a person, and this is the other person, and how are you feeling? And we'll put some sort of feeling in the bubble next to the heart. And what did you do? And then we'll draw something like, so you threw a book, you threw something, or you hit this person. And what were you thinking? You were thinking. And we help our kids identify what they were thinking that led to that level of anxiety and reaction, or avoidance. And then you'll say, what other things could you think? And then you'll try to replace them with some of these more adaptive coping strategies, like, you could think, there is nothing to be afraid of. I can always leave. I'm going to be successful. So reversal of your own negative thoughts,
So really empowering them.
Oh yeah, absolutely. Rule lists of emotions for coping, rules lists of what's normal and what's excessive. Keep in mind, none of our kids really know how to do these things. They don't really know.
They don't have a reference point.
They don't. They really don't. And I'm just going to keep going. I know we're going over a little bit, but I want to get through just maybe this slide.
And I've got a couple
the next
of
slide
questions
is the last slide.
touch on.
Absolutely. Okay. Now, let me just give some more examples. Use concepts that are interesting. For instance, astronauts exploring a new planet, right? That's a really good example, because imagine for our kids, it feels like they're exploring a new planet, right? And if you show them, look at those astronauts and look what they did, and you're exploring, so go and see what's out there and come back and tell me, and that gives them courage. Or like there was one child who had a Harrison Ford obsession, like was completely, and the way that it was, the strategy was used to just say, what would he do? What would Harrison Ford do? And then whenever we drew comic strips, it was always Star Wars cartoons, right?
Fun.
Or use self-stimulatory behaviors as a way to reward themselves. This is called the Premack principle, where essentially you will allow the individual to, for instance, use line certain things up that don't seem as odd.
Okay.
Like for instance, how many people have, engineers, I love when they have like 10 really sharp pencils in their pocket, or
Right.
mechanical pencils or something, or when we have like a pencil case and all of them have to be like sharp, or hey, how many people have really, really organized sock drawers or whatever
Right.
it is. Hey, allow those things because they're adaptive ways of being obsessive.
Right.
Okay, and just don't allow the ones that are not. Like, as I said, organize. Let your child be obsessive in certain arenas, but just not others.
Okay.
I think the last slide is just talking about, like really take care of the anxiety in yourselves, because the more anxious you are, it really does affect our kids as well.
It starts at home.
Yeah.
As always.
And let's see if some of I do want to tell our parents about our viewers about one type of therapy called acceptance commitment therapy. I'm pretty sure Evelyn Gould would have talked about this.
Yes.
It's a fabulous intervention. It's a fabulous type of treatment. I really recommend it for a lot of people. It helps you cope with anxiety. It helps you cope with fear. It helps you accept things. I know, maybe next show we can get into, Shannon, how just having your child diagnosed with autism causes a lot of anxiety.
Yeah.
And how we can really help our parents cope with these things. I've put in some of the things, some specific treatments. Actually, what we should do is talk about just ACT in one of. Has Evelyn done that already?
She has, but we can. There's always more to talk about.
Okay.
So absolutely, I want to get to a couple of these questions, and one of them, it's going to be seemingly off track, but it's a 911 from a parent who's having anxiety right now because their child is about to go in and get tested for diabetes, and they write in and say, "I know gastric issues are common with ASD kids, but is diabetes common? My son is being tested in 30 minutes again for this, and he is only 4."
Right. I don't know that it's common. I don't have too many kids with diabetes, so it might not be common, but doesn't matter.
It's important to get the test.
It's very important to get the test, and don't worry, don't freak out. It's not a big deal. There are so many children who have diabetes and they handle it and they learn to cope with it and they learn to self-inject, and it's not or check their own blood later on in life. He's 4. I know. I hear your pain. I honestly do. But don't see, this is what I'm saying. This is what happens. We become apprehensive about stuff we imagine.
Right.
Maybe it's good for him right now. Maybe later in the future we learn that we all need to watch our insulin levels. Right. Just go with it.
And if it comes back positive, it means that he needs some help, which you would do. So
and
this is a good thing that you're
exactly.
Yeah,
and it's so important to know. Right.
And somebody wants to know, it's sort of that chicken or the egg. Does anxiety cause the stomach issues, or is it the other way around?
Oh, I love the person who wrote that in. That's part of the one of the slides that I had to take out because this is so long. I always think that myself. Which one is causing which? Very, very good point. And they perpetuate each other, obviously. Absolutely.
Absolutely. So the answer to that is we don't know.
We don't know.
And it could be different in different kids, couldn't it?
Absolutely. And when you look at kids with autism, if you think about, and I've said this on the show many, many times before, but if you think of kids with autism as, just put yourself in there. That was my Hong Kong experience. It's kind of like, okay, you have sounds that are too loud, lights that are too intrusive, you're not sleeping well, you have GI issues, you're not comprehending much of what's going on around you.
Right.
Believe me, you will feel anxious.
Yeah. And as you said, that doesn't have anything to do with autism necessarily.
No.
That could be any kid, any of us. You're having GI issues, you're going to get anxiety, and if you have anxiety, you're probably going to get GI issues.
Absolutely, that's right. right. You take any typically developing child, fly them to some other part of the world, make sure they have jet lag, and throw them in a school where they don't know how to communicate with anyone, and the culture.
Mess with their diet.
Mess with their diet, and their culture is completely different, and believe me, they'll react just the same.
Okay, next question. Can children outgrow anxiety or separation anxiety? Is it just being a child and feeling small in the world that can trigger it?
Whatever the trigger is, you need to act in order to get them off of separation anxiety. Separation anxiety is often because we give in. It's our kids will probably start. So here's how it goes. That's that slide that I said a lot of times this is something that is instigated just naturally. Okay, so of course your child is bonded with mom and dad more than anyone else, or mom and someone, caretakers, guardians, people they feel safe with. And now you're putting them in a school environment where they don't know anyone, so they're going to feel unsafe, which will equate to anxiety. But you have to go back and you have to do a planned intervention. And it's exactly what I said. It's the systematic desensitization. Graduated exposure to the school environment with coping strategies will help your child get over it. And if you don't do that, no, there are children who have separation anxiety even at the age of 10. There are adults who have separation anxiety because nobody ever helped them get through it.
Okay, so we shouldn't have an expectation they're just going to work it out on their own.
They might, and the only reason they work it out on their own is because they're flooded, they're thrown into the scenario, and they realize they're safe.
But that isn't necessarily the kindest way to do it.
It isn't, and it's not the guaranteed way that they'll get through it.
I sort of feel like we've answered this a little bit, but I want to backtrack a little. Does this apply to kids without autism as well?
Absolutely.
It applies to all of us.
It applies to everyone. We all experience anxiety. It's just a matter of whether we have the ability to cope with it at different levels or not.
Okay.
And, a lot of people, as I said, remember the first slides, a lot of people deal with it in adaptive ways, not adaptive ways, and the issue here is to try to teach our kids more useful and adaptive ways to cope.
Okay, this next one comes from, I don't know if you remember, the first time I ever had you on a radio show, the first caller that we got, it's this person who I've become very good friends with.
Wonderful.
But wants to know, they're having lots of problems with OCD-type behaviors. The older her son gets, he's now a teenager, the more pronounced they are, and he's had 5 black eyes self-inflicted in the last 3 months simply out of frustration because his OCD needs aren't being met.
Okay. This is a very severe situation. Here we go. Is he on any medications? Get him on an SSRI medication, first of all, please. That will help take the edge off him immediately. It will really significantly help. Secondly, start from scratch. Allow him to have all of his OCDs for a while. Okay, start with that. That's your baseline. Start working on teaching him some other techniques, relaxation techniques. Does he know how to meditate? There are very, very good tapes out there. I don't know what his functioning level is. Perhaps you know, Shannon, but there are amazing tapes or DVDs or CDs, even online, that you can play that are 5 minutes, 20 minutes, that they will literally take you into a dream state and they calm you absolutely, and they're beautiful, and it's visual imagery. Maybe that doesn't work for him. Maybe music works for him. Get him some headphones that are noise canceling, put them on, and allow him to listen to calming music. Maybe rocking calms him. Teach him something that is calming. When you've identified what that is, do desensitization. Start to talk about the worst thing in his case is his routine not being done, his compulsion not happening. Okay, I don't know what they are. The easiest is one step away from it now. So in other words, let's say he has a compulsive behavior of lining up objects. The worst thing that could happen is he's never allowed to line up objects, or someone disrupts his objects all the time. Just as an example. What if you start with the lowest being, we disrupt the line, but you can form it again immediately. Okay. And you just make the hierarchy all the way up. This hierarchy will differ based on each individual's actual fears and compulsions. Start gradually teaching him how to cope with change.
But wouldn't you say at this point it's important to get some extra help, like you were saying, get some medical help, but also time to get maybe a cognitive behavioral therapist, you know?
Definitely. I mean, if you have a child who's now an adolescent and is giving, you know, self-injuring,
Yeah.
he's scared to death. Yes, please get him help. Please get him help. Get him medical help, and get together with a cognitive psychologist.
Okay, great. And our last one, how do we deal with anxiety with adults, not just children on the autism spectrum, young adults that go into transition or higher education and independence sometimes face anxiety with the changes in this transition. We see this as a growing field. As more of our kids get better and they go out into the world, they're having anxiety. Any advice for young adults with autism that experience anxiety with these transitions?
Absolutely. And we could, I mean, I'm happy to do another show that just answers questions, but again, ask yourself, what tools do they have? What's their toolbox consist of? What do they have when they go out there? Is it a physical fear or is it a mental fear, right? Do they have books they can read that helps them to calm down? Do they know how to meditate? Do they have all their favorite music? Do they have all friends? Do they know how to connect with you when they need to? What are the tools that you've given them? And just, you know, maybe read the information that I'm sending here on ACT that will actually help you teach them ways to reevaluate. See, what we do with our fears is we tend to label them, and then that becomes scary.
Yeah.
But, you know, there's a lot of different techniques that help you just calm down. If your child or adolescent is leaving, and my daughter just went to college, obviously there's a ton of anxiety involved with it. I think there have been days where I've just finished work and gone straight up to Santa Barbara to spend the weekend with her, or just the week, you know, or a day or two. So you do a graduated thing. She basically doesn't need me anymore right now there, but she did at the beginning of the term. So you observe those and don't panic about them, and you get help.
And somebody wrote in and said, thank you for this amazing information, very helpful, and as a parent I feel that I have some clear ideas on what to do with my 9-year-old.
Wonderful.
So thank you.
I'm very glad.
And we have to let you go now. We have to, because we've kept poor Nancy Allspaw Jackson waiting. But I do want to say that the next time that we'll be doing Ask Dr. Doreen is on January 8th. So we'll continue.
Sadly.
Well, because the next two weeks are holidays. But you'll be able to go back and watch this and the first one. And when we come back on January 8th, we'll be answering questions. So we'll keep questions, and you guys can write in after you've thought some more and tried some of these things and ask some more questions.
And I really want to wish our viewers a wonderful Christmas or any other holiday that you're celebrating right now, and a happy, happy, happy New Year. I'm really looking forward to 2014, and may all of your children continue to do well and flourish, and may 2014 be a peaceful and healthy and just a wonderful year for everyone.